stenosis. What is stenosis? Stenosis is narrowing of the lumen of the blood vessel, produces disturbed and turbulent flow. Speed in stenosis must be greater than the proximal and distal to it, and the pressure must be less than proximal and distal to it for flow to occur in the stenotic area. Volumetric flow rate is constant before the stenosis, at the stenosis, and after the stenosis according to the continuity rule. What's the causes of stenosis? Normally, atherosclerotic diseases, that's the most common cause for stenosis, and formation of a plaque. Okay, so if you see here, this is the blood vessel. It has a big plaque building inside the blood vessel, making the lumen of the blood vessel very narrow. See, the diameter before the stenosis is reduced. The area of maximum stenosis, the diameter is really very small. So stenosis is narrowing of the lumen of the blood vessel and decrease in diameter of the blood vessel. And the most common cause is atherosclerotic disease and plaque formation. Okay, so here, this is the narrowing of the lumen of the blood vessel, and this is stenosis here. The diameter is really reduced. What happens at the site of stenosis? Velocity goes up, pressure goes down. If you check pulsation at this point, there will be loss of pulsation. There might be little reversal flow or change in direction of flow. And after the stenosis, we always get this type of flow, turbulent flow. Post-stenosis, we get turbulent flow. So narrowing or irregularity in the lumen of the blood vessel is stenosis. Stenosis may have the following effect in the blood vessel again: change in the flow direction, increase in velocity at the stenotic area, and decrease in pressure and turbulence at the post-stenosis or after the stenosis. Okay, and there is loss of pulsation. This is really important to know the effect of stenosis on the blood vessel. There might be change in flow, increase in velocity at the area of maximum stenosis, turbulence post-stenosis, pressure decreases at the area of maximum stenosis, and loss of pulsicity. Okay? So how do we measure the velocity of flow? If you get your waves here, you get your pulse wave, and then you measure your peak systolic and end diastolic, the machine will give you the velocity. And how do we know the degree of stenosis? Because if we have a small stenosis, we just treat the causes, like try to treat the hyperlipidemia or increase in cholesterol level, because that's what causes the atherosclerotic diseases and damage to the wall of the blood vessel. Okay? If it's a small plaque, then we just treat the hyperlipidemia and follow up with the patient. Okay, but if you have a stenosis of 80 to 90%, if we don't treat this patient, is going to go to full occlusion. Stenosis is narrowing of the lumen. Occlusion is complete loss of the lumen of the blood vessel, complete blockage or obstruction of the blood vessel. Okay, so how do we treat patients with stenosis? We have to, it's a surgical treatment if it's 80 or 90% stenosis. And that surgery is called endarterectomy, where we scrape or take out the plaque from the blood vessel. Okay? So this treatment is not done for every patient because it has a lot of risk factors like bleeding, and if there is a small fragment or emboli, can cause a stroke or damage to tissues in other places of the body. Okay? So the velocity is measured doing checking the peak systolic and end diastolic. And after you get the velocity, you look at the table and see what will be the degree of stenosis. Okay? Like here, you look at the peak systolic velocity. If 125 is already like 15%, more than 125 is 79%, and so on. Okay, so we get the velocities by measuring peak systolic and end diastolic, and we look at the table and see what's the degree of stenosis or the percentage of stenosis. Okay, so the continuity rule, as we said earlier, is said that the volumetric flow rate before the stenosis, at the stenosis, and after the stenosis should be the same. How can we have that big Q pass through this small tunnel to have the same volumetric flow rate before the stenosis, at the stenosis, and after the stenosis? how can we have that happen, okay? Bernoulli came up with a solution. So what we call Bernoulli's effect. What did he say? At the area of maximum stenosis, if two things happen, then we will have the same volumetric flow rate, or Q, before the stenosis, same as at the stenosis and after the stenosis. What should happen at the area of maximum stenosis? Bernoulli's effect said if there is decrease in pressure and increase in velocity at the area of maximum stenosis, then Q will be the same before, at, and after, okay? So what is Bernoulli's effect again? At the area of maximum stenosis, pressure goes down, velocity goes up, okay? That's Bernoulli's effect. So at the stenosis, flow speed is high, but pressure is low. That's Bernoulli's effect. Pressure energy is converted to flow energy at stenosis, as it is necessary to allow high flow speed. Bernoulli's effect is, again, that could be a test question, Bernoulli's effect. At the site of maximum stenosis, pressure drops down and velocity increases. Okay, so if you look here, this is the carotid artery, and this is atherosclerotic disease. You see the lumen of the artery. There is a hyperechoic structure sitting in there. It's very thick. It's even causing shadowing. Okay, that's a plaque. In atherosclerotic diseases of the carotid artery, occurs most commonly in the proximal internal carotid artery within the first 2 centimeters of bifurcation. Plaque can reduce the cerebral perfusion and can be a source of emboli, and immobilization results in a stroke when a small piece or fragment from this plaque travels with the circulation and blocks smaller vessels in the brain, so that area, with every area of the brain is deprived of oxygen supply and blood supply because of the occlusion. That will result in infarction of that area and loss of function of that area, and that will be a stroke, or we'll see some neurological deficits on the patient. If it's a very small, tiny piece and it's washed quickly, the patient will experience the neurological deficits for only 24 hours, and we call that the transient ischemic attack. So what is this plaque that causes the stenosis or of the lumen of the blood vessels, or narrowing of the lumen of the blood vessels? First, lipid from blood accumulates in the subendothelial layers. Then lipid material is ingested by macrophages, and smooth muscle cells migrate from the muscle layer of the subendothelial layer and become transformed into fibroblasts. Okay, so this is how the plaque forms, and that's what really causes the stenosis in most arteries is atherosclerotic diseases and plaque formation. This is the plaque here. You see how it is causing stenosis or narrowing of the lumen of the blood vessel. Okay, and it decreases the surface area. The total surface area, cross-sectional area, is also reduced. Okay, so that's the circumferential plaque is going all around the blood vessel, or it could be only to one side of the blood vessel. Okay, so if you look here, we have a stenotic blood vessel. When we're doing our vascular study, or we're checking the velocities here in this blood vessel, I'm going to go and get my waves before the stenosis, at the stenosis, and after the stenosis. Okay, so brief stenotic region, look for increase in resistivity and pulsicity in the flow. A stenotic area, we will see increase in velocity, and of course that's the area where we have the maximum stenosis. Pressure goes down, velocity goes up, so we look for that increase in velocity. And post-stenotic region, look for increase in turbulence. We remember what kind of flow we have post-stenosis is turbulent flow. What turbulent flow? Look at the waves here. My waves have clear windows before the stenosis. At the stenosis, you see how the peak systolic velocity increases. And after stenosis, we see the waves lost the window, the waves with no window. The window is filled with frequency. I see solid wide waves, no windows. What do we call this? If you look at the second diagram in here, When there is loss of window, this is called spectral broadening. And spectral broadening happens with turbulence. Turbulence is not the only cause for spectral broadening. It's not like whenever we have spectral broadening is turbulent flow. It could be an artifact created by the sonographer if you put the gate close to the wall. So if you look here, I put my color box and gate in the center of the blood vessel. I adjusted my angle, adjusted my cursor, and I push pulse. I kept my angle between 45 and 60 degrees. I push pulse wave, I got my waves, I move my color box to the area of maximum stenosis, did the 5 steps, got my wave, okay, and then I do the same thing after the waves, okay, or after the stenosis. So I did sampling from 3 different regions, pre-stenotic, at the stenotic area, and post-stenotic. As we said, if I have my clear windows here and pre-stenotic waves at the area of maximum stenosis shows increase in peak systolic velocity. And after the stenosis, I lost the windows, and this is what we call spectral broadening. Why do I have spectral broadening? Because post-stenosis, I have turbulent flow. And whenever we have turbulence, we have spectral broadening when the window is filled with frequencies. See, the velocity at the area of maximum stenosis will go up. That's Bernoulli's effect. That's the only way we'll have the same volumetric flow rate before, at, and after the stenosis. So at the stenosis, we said 2 things should happen. Pressure goes down and velocity goes up. It depends on the degree of stenosis. Like in this case, this is like 90% stenosis. The velocity is going to be so high, it might exceed the limit. Pulse wave has limitation of velocity by this NL. What is NL? Nyquist limit. So if your velocity exceeds this Nyquist limit, the tip will wrap around, and I see it on the negative side. What do we call this? That's called aliasing. When the velocity is so high and it exceeds the Nyquist limit, we'll see aliasing. When the tip wraps around and you see it below the baseline. And after the stenosis, we see spectral broadening. So this case here is a 90% stenosis. My velocity at the area of maximum stenosis is so high, it exceeded the Nyquist limit, and that's why the tip wraps around and I see them on the negative side, and that's called aliasing. In this case, how can I measure the peak systolic and end diastolic to get my velocity? Because I need to get the velocity to know the degree of stenosis or the percentage of stenosis. So how can I get my peak systolic? We have to fix the aliasing. Okay, so the lower line is called the baseline. I can pull this line down. That's the baseline. That will fix the aliasing. The tip will go back on, and I can measure my peak systolic. Or lift this line up, the Nyquist limit, increase the Nyquist limit. There is no key for Nyquist limit, but this Nyquist limit equals PRF divided by 2. So if I want to increase the Nyquist limit, I can increase the PRF. But there is no key again to do that. So the key I use to increase the Nyquist limit or increase the PRF is increasing the scale. The key is scale. I can increase the scale. That will increase my Nyquist limit, and the tip will go back on. Okay. Another way to increase my PRF is to switch to shallow depths. Remember, if your depth of view is very small, more pulses will occur, and that will be high PRF. So to increase my PRF, I can switch to shallow depth, or I can use continuous wave transducers. Continuous wave transducers have no limitation of velocity and no aliasing. Or I switch to a low frequency transducer. Low frequency transducers have less aliasing. What do we see here? I see waves with no windows. The windows are filled with frequencies. What did we call this earlier? Spectral broadening. Where do I see this kind of waves? Wherever I have turbulent flow. Like post-stenosis, I have turbulent flow. So after stenosis, I will see spectral broadening. Is that the only reason for spectral broadening, turbulent flow? No. It could be an artifact created by the sonographer. If you kept your gate wide or close to the walls instead of the center of the blood vessel, you can get turbulent flow. Or if you scan close to 90 degrees. Here, this shows here we have plaque formation and narrowing of the lumen of the blood vessel. Okay, so in this case here we have occlusion, total occlusion, where you see there is no flow in the middle. So it's not just stenosis or narrowing of the lumen of the blood vessel. Color flow should be used to differentiate between occlusion and very severe stenosis. Very severe stenosis near occlusion will show no color if the color control settings are not optimized for very slow flow or trickle flow. Power Doppler would be better to detect that trickle flow. So if you switch to color Doppler, you can see like a thread flow or trickle flow if you have near occlusion or very severe stenosis. You will still see some flow if you use color power Doppler. If you see here, we have a plaque formation inside the blood vessel causing stenosis, and we said if this plaque is old, start to ulcerate and fragment, small pieces can go with the circulation and occlude blood vessels in the brain and cause stroke. Here, this the lower diagram in here to the left is showing angiography. That's a gold standard test when we put a contrast agent, inject it and look inside the blood vessels for flow. There is area where you just see a trickle of flow. Do you see this? Okay, so that's detecting an occlusion or near occlusion, very severe stenosis of the artery.